Good evening, good morning, and good afternoon, everyone. I would like to warmly welcome you to our virtual grand rounds in radiation oncology. The format, you've known it now for about 2 months. It's a very rapid, short virtual meeting to show the latest science, top speakers in a very interactive format. It's happening on every first Wednesday in the month from 5 to 5:30. And we aim to bring you the latest science and also provide that in a 15 minutes time frame for a presentation to have sufficient time for questions and answering thereafter. I would like to warmly thank our societies which are supporting and which are endorsed this symposium. It's the Astro Society, the SASRO, and the DEGRO. And this is an overview of the last meetings we had. We had Professor Niklas van Ask presenting the PACE trial, David Palmer addressing oligometastatic disease, and today Andreas Rimner. Please be aware that the meeting is being recorded. So if colleagues might have missed the meetings, they are available on our meeting webpage, which is shown below. If you can't kind of copy it now immediately, just search for virtual grand round in radiation oncology in Google, and then you will be directed to our homepage. So today it's a pleasure and honor to announce and to introduce Dr. Andreas Rimner. He's director of the Thoracic Radiation Oncology Research Program and an associate attending at the Memorial Sloan Kettering Cancer Center in New York, where I just learned it's beautiful outside, sunny but cold. He's also vice president of ITMIC, and he's member of the ILSLC Staging and Prognostic Factors Committee. The topic of this session is slightly more preclinical or translational. The question we asked Andreas is, can radiotherapy for lung cancer be guided by circulating tumor DNA? Circulating tumor DNA feels a bit like teenager sex in a way. So everyone has been speaking about it for a long time. We've heard so many presentations, heard about its promise, how fascinating it is, but it was difficult to see its wayfinding into clinics. You know, the dynamic trial has been published in the field of medical oncology in colorectal cancer patients, which showed that by using ctDNA, we can guide the adjuvant, the systemic therapy treatment, and thereby maintain the outcome and simultaneously reduce the patients being exposed to systemic therapy, chemotherapy in that setting. So the question is, how can we implement this promising technology into the field of radiation oncology? And Dr. Rimner is an obviously expert in this field. He has been a co-author of a Nature Medicine publication, Overall Survival with Circulating Tumor DNA-Guided Therapy in Advanced Non-Small Cell Lung Cancer. And also he translated this question into radiation oncology, lung cancer, patients being treated for stage 3 and 1 non-small cell lung cancer. Andreas, many thanks for joining, and we're looking forward to your presentation and the discussion thereafter.
Thank you very much for having me. Let me share my screen. Are you able to see my slides fine?
We are now in presenters mode. Now it's perfect. Thank you.
Okay. All right. Thank you very much, Matthias, for having me. It's a lot to pack into 15 minutes, but I'll try my best, so I'll have to talk a little bit faster. Can radiotherapy be guided by circulating tumor DNA today? If you want to keep the talk really short, I'll just say no. I think what we are beginning to do is we are beginning to understand the dynamics in the context of radiation therapy. And I think our first attempts of using it in a clinical way is to guide adjuvant or consolidative therapy or monitoring for early recurrence. And I'll show you the data behind that. We may very well be translating that into guiding radiation therapy in the not too distant future, but not as of today. Here are my disclosures. The only one that's related is that I will show a brief trial schema of a trial that we did with AstraZeneca, and the others are not related to this today's presentation. So liquid biopsy is essentially the detection of non-invasive tumor-derived material. So it's essentially a blood draw that can detect components of the tumor. We founded a liquid biopsy group at Memorial in 2017, and in the beginning we were 3 people. That was Dr. Bob Lee in medical oncology, Jay Isbell from thoracic surgery, and myself. And we started by collecting samples really on our patients in the surgical medical oncology and radiation oncology realm. And essentially what you can do is you can detect circulating tumor cells, the cells overall, or the subset of cell-free DNA that is being shed from circulating cells or cells that are dying and the DNA is released into the bloodstream. And so that is really what this technology is trying to do. Sorry, I just need to move this. Where does this circulating DNA come from? A number of things. So apoptotic bodies can release DNA, and there's different things that you can go and detect. There are point mutations, which we all know about. There are copy number alterations. There are more complex rearrangements, like for ALK fusions or so in lung cancer. And there's methylation changes, which some of the most prominent assays are actually focused on. And then there's exosomal DNA, which is a separate area that can look specifically for viral DNA, for instance, for HPV or so, which is a nice target for detecting it in the bloodstream. Of note, ctDNA has a very short half-life, which makes it, on the one hand, practical because it's very strictly correlated with tumor presence. On the other hand, it makes it challenging because it also drops very quickly and can be difficult to detect. So here's an example from a surgical paper where after removing the tumor, you can see how the DNA fragments, for example, drop very rapidly after the tumor is taken out. Now, whenever you have a tumor-associated mutation, then it is much easier to actually detect tumor DNA in the bloodstream. And in the case of lung cancer, there are common driver mutations such as EGFR, KRAS, MET-ALK, and Emily Lebo, who was a resident in our department, is now at the University of Pennsylvania, published this paper in JAMA Network Open, where she correlated the presence of mutation with the detectability in peripheral blood. And so if you have a known mutation from whole genome sequencing of the primary tumor or even targeted sequencing of the primary tumor, then you know what you're looking for and you can design a probe to look specifically for that mutation. And so that significantly increases the detection rate. Justin Hazeltine, who was a resident in our department, is now an attending here at Memorial Sloan Kettering. In the early days, started by correlating tumor volume with ctDNA detectability, and we at that time worked with Resolution Bioscience on a collaborative basis, so that's why there's no disclosure. But they had an assay at that time that looked for specific known mutations, and so we looked at 110 patients with advanced lung cancer, used their 21 gene assay. And then Dr. Hazeltine went back and contoured all the tumor burden on PET, CT, and MRI of the brain. And the 78 patients that had at least one known mutation, we were able to correlate with the tumor volume. And so you can see that if you, with a higher tumor volume, there's a greater rate of detection, and it also correlates then with survival. If you can detect the mutation in the peripheral blood, it's associated with worse survival. The only exception for that is if you have a targetable driver mutation, then with the matched therapy, it actually, those patients do better in overall, and their overall survival is improved as an effect of or consequence of the targeted therapy. Now, I'll make a little joke here for the medical oncologists in the audience and the radiation oncologists, because if you do essentially the same study that Justin Hazeltine did on 78 patients or 110 patients to start with, and you do that in over 1,000 patients in a medical oncology setting, you get to publish the same paper in Nature Medicine as opposed to in translational lung cancer research. But what we did here in our very close collaboration with our medical oncologist, Justin G is an extremely talented medical oncology fellow who's also now joined us on the faculty and worked with Bob Lee and Emily Lebo, the resident that I mentioned earlier, together with Randy Ye from radiology, was they did a large study of all the samples that we had prospectively collected until that point, and they did a semi-automatic volumetric analysis based on PET with a 41% SUV max threshold, and then they correlated ctDNA burden again with a PET signal and the metabolic tumor volume overall, and again showed a clear correlation with ctDNA presence and tumor volume as well as survival. So now that we know that we can detect it and it correlates with tumor volume, how can we make it practical and how can we use it to detect minimal residual disease? Because as we all know, lung cancer is oftentimes a systemic disease. It's when it's caught early, it can be addressed with local therapies, but it very frequently metastasizes and has a high rate of metastasis. And therefore, we would like to understand who has minimal residual disease that is at recurrence for relapse. And if we can detect that, how can we adjust our therapies accordingly? And I think we're right at that point where we can actually make it practical and pragmatic. So is minimal residual disease at baseline detectable at baseline? It has to be in order for us to really reliably detect minimal residual disease in the post-definitive treatment setting. I already showed you the prognostic value. And then the other question is, what's the lead time between detecting it in the bloodstream and the radiographic or clinical relapse? So Emily Lebo worked with us on all the patients that had localized non-small cell lung cancer, stage 1 to 3. And we whittled it down to about 17 patients where we had tissue that we were able to sequence, as well as liquid biopsies at multiple time points. So a total of 70 blood samples. And I just want to note that this was 17 out of over 150 patients that we had collected blood on. So you can see how quickly it narrows down if you select by having pathology samples available, as well as being able to detect something in the bloodstream. So these were all patients with stage 1 to 3 lung cancer treated with definitive radiation, and we then surveyed them per routine and drew blood along with that. We worked with Natera on a personalized tumor-informed assay. So unlike what I mentioned before, where we have a known mutation, these were patients that did not need a known mutation, but we took their tumor, sequenced the tissue, and then designed a probe that was unique to that patient's makeup. So it doesn't have to be a driver mutation, it just has to be the unique tumor mutational pattern in that tumor, and then a patient-specific probe. So fairly labor-intensive, but by doing that, we can actually detect or go after circulating tumor DNA without necessarily needing a driver mutation, which only a minority of patients have. And with that, we were able to detect 100% of stage 3 lung cancer patients, and even almost 60% of stage 1 and 2 lung cancer patients in the peripheral blood. And that is, to our knowledge, the most sensitive assay that we have seen in the definitive radiation setting. So even if you have only a 1 centimeter lung nodule or so, you can actually detect circulating tumor DNA in up to almost 60%. And that is probably because we had this unique tissue-informed and patient-specific assay. Now that will really then open up the door to use it in the majority of patients when you can detect it at those early stage patients already. And so what we saw here was, we took multiple time points where we drew the blood, and then we would monitor the patients as well as their ctDNA. And the black dots are ctDNA positives and the white dots are ctDNA negatives. And so here's an example of someone who just continued to progress and then had a recurrence in the spine. And here's someone who dropped right after definitive radiation and stayed always undetectable and never had a recurrence. And when plotting that as progression-free survival, and especially if you do multiple time points, we had 100% survival in the ctDNA negative patients, and you can see how rapidly the patients progressed that had ctDNA positivity in the longitudinal setting. So it very strongly correlates with clinical recurrence and disease progression. Now, what's the lead time? It's actually 5 months. So 5 months before we saw a radiographic recurrence, we were able to detect the ctDNA in the peripheral blood. And that's arguably a clinically useful time frame where you actually have an ability to intervene earlier. And here are the examples of the time frames between ctDNA detection and imaging. And so this whole work was published in Frontiers in Oncology just a few months ago. So what can we use it for now? We can use it to just risk stratify, right? You can detect it, you know someone will recur earlier, but that's maybe nice to know, but not really where we want to end up with. And we can say, you know, you'll do well if you have a quick ctDNA clearance and you stay cleared. But really what we want to get to is minimum residual disease guided therapy. So we would like to have a patient that is being treated with surgery or radiation in the early stage setting. Then we monitor them. If they become ctDNA positive, we would like to know whether we can intervene earlier with adjuvant therapy, let's say. And if they're negative, then of course we just continue to monitor them. So KRAS is a very common mutation in lung cancer, and my colleague Dr. Shaverdian, who is an assistant attending here at Memorial, has focused on that, and it's well known that KRAS mutations are associated with worse outcomes in lung cancer patients. And so he's designed a randomized phase 2 trial where we are looking at patients with KRAS G12C mutations, for which there's a targeted drug now, sotorasib. And if we monitor them after chemoradiation and definitive chemoradiation, and standardly they would get immunotherapy, durvalumab, if they have detectable ctDNA early on, we will randomize them to get the standard of care durvalumab or switch them to the targeted therapy for KRAS, sotorasib. And the primary endpoint is progression-free survival. And this study is an investigator-initiated trial that is funded by Amgen and Guardant, but I have no disclosures related to these companies. Dr. Shaverdian does. Similarly, we have really built in ctDNA in all our currently ongoing prospective trials as a correlative. This is the DART study that we have just completed accrual to. So patients that are not candidates for concurrent chemoradiation are getting radiation alone without chemotherapy and durvalumab concurrently, and followed by durvalumab consolidation therapy. And the primary endpoint is progression-free survival, but a secondary endpoint is early response by ctDNA. And we will actually probably make that a co-primary to just correlate it with PFS. This is an investigator-initiated trial funded by AstraZeneca, which is what's related to my disclosure. Now, just one last thought is that we're not only able to monitor tumor DNA, we can also monitor normal tissues that release circulating DNA. For instance, when there are stressors from therapeutic intervention. And my colleagues, Dr. Moore, who was a resident with us and is now an attending here, and Adam Schmidt, who has a lab and is an attending in the Department of Radiation Oncology, have done a lot of work on normal tissue damage. And so there are unique methylation patterns that are unique to each tissue of origin. So they've focused on lung and heart. I'm just showing the data on the heart. So you can actually get cardiomyocyte specific circulating DNA in the bloodstream. And then you can correlate that with sepsis, you can correlate that with myocardial infarction, but you can also correlate it with cardiotoxicity from our therapies. In this case, they used a set of breast cancer patients that were treated with doxorubicin and cyclophosphamide, and then trastuzumab and breast radiation therapy. And the patient that had cardiac dysfunction based on echocardiograms had an increased level of circulating cardiomyocyte cfDNA. And that was just published in JAMA Cardiology. So not only can we use it to monitor tumor recurrence, we can also correlate it with toxicity. And this is the first attempt at that. We are looking now also into patients from a pneumonitis trial that we performed here, and looking at circulating DNA from lung damage with a methylation specific pattern. So in conclusion, the detection sensitivity of current circulating tumor DNA assays is now finally at a point where we can actually detect it even in patients that are non-surgical candidates, which is always our challenge, right? We only have small biopsy specimens in our radiation patients. And so now it's really getting into a space where it's pragmatic and doable, actually. It's clearly a biomarker for disease presence and volume, as well as disease progression. The new clinical trials are now incorporating these assays into their design, and they're ongoing or in development, and we are not the only ones. And ctDNA may also allow for broader recurrence screening or pan-cancer screening, something that I haven't talked about, but what our resident Dr. Raouf, who I mentioned earlier, is very interested in. So you can actually use it as a screening tool, and there's a lot of work going into that. And then lastly, cfDNA is also a marker for normal tissue damage and may be able to be used to predict and manage treatment-related toxicity. So with that, I'd like to thank you for your attention. This is obviously the work of many people. I mentioned Dr. Shaverdi and Dr. Schmidt, who are my colleagues here, and the work of multiple residents who are who did residency at Memorial and are now at Penn or have gone on to be attendings here. And Dr. Raouf is still an excellent, very talented resident who's still working with us. Our medical oncology colleagues with whom we collaborate very well, and thoracic surgery as well as radiology. And you can see that the group of 3 people has now grown to this group of, maybe 20, 30 people. So this is now the liquid biopsy group at Memorial Sloan Kettering. And then just lastly, in case you were interested in anything that I said today, starting February 1st, I will be starting a new job at the university in Freiburg. And this will be my new address and my new email address. So if you are interested in working with me or, just brainstorming ideas, please contact me. I'll look forward to, discussing this further. Thank you very much.
Thanks, Andreas, for an excellent presentation. We warmly welcome you back in the European side and looking forward to many collaborations between our centers and obviously within the European framework. Everyone who's being interested and wants to ask questions, you can do so. We have a chat and the question and answer tools, and please use them. I would like to start with the first question being by Gerard Waltz. Congratulations on the fantastic studies and keeping up with RADONC with MEDONC. Do you believe ctDNA kinetics during treatment, I guess that's during radiotherapy, maybe conventional fractionated, will have any utility as the predictor of radiotherapy tumor response? So even earlier than maybe the kinetics waiting for a few weeks?
The short answer is we don't know quite yet. We had built in an early time point at 3 weeks. All the patients in our studies were in the stage 3 studies were obviously treated with a 6-week course of radiation. So those had a 3-week time point, but there were not enough patients to really make any strong conclusions. Similarly, the phase 2 trial is only stage 3. In the Natera study, we did have, as I showed you, a handful of, about half of them were stage 1 or 2, and they were treated with SBRT, but again, not really enough patients to make a strong statement on the kinetics during radiation. But that's clearly the next step. In surgery, our surgeons have actually done similar studies, and actually sometimes seen a slight increase right after surgery as the tumor was manipulated, followed by a quick drop. But surgery is, of course, a much more definitive and quick and decisive stopping of ctDNA shedding into the bloodstream once the tumor is out. So it's a little bit more predictable probably in the surgical patient population.
Maybe an immediate follow-up question. Have you looked at the outcome of these patients where you see a spike in ctDNA after surgery that might also be associated with worse outcome? Has that been looked at?
Not that I know of, no. But yeah, good question.
Other question, referring to identifying patients who are ctDNA positive upfront. You show data from your personalized panel where 100% of the patients having stage 3 disease were being positive, but the rate dropped to about 40%, I think it was 60% in stage 1. Is that tumor volume related? And if you could translate that to an oligometastatic setting, is it the number of metastases? So what are parameters, clinical parameters, which help us to identify patients who will be in the end a ctDNA positive upfront?
Yeah, so we tried looking that in Dr. Hazeltine's study and in Dr. Ye and G and Libo's study, and that was actually more difficult than we anticipated. So it seems like the ctDNA is, well, it clearly correlates with volume, yes. But number of metastases, number of organ sites involved, and all of that, we looked at.
And organs involved, is it different between bone mets, liver mets, lung mets? Is there any difference?
We tried, it wasn't all that clear. We had the same thought, but maybe it's a limitation of the numbers. Even though we had like 100 patients or so, we didn't specifically look at that in the Nature paper. But yeah, it may be that we just need more patients with a broader spectrum of organ involvement and tumor volumes.
Then there's two questions about the dynamics, in particular the dynamics in respect to the treatment intervention. What is the difference in dynamics between surgery, conventional fractionation, and SBRT? Is there any difference? And also in the MRD?
Yeah, I think the drop is clearly different. The drop with surgery is much faster than with any radiation, naturally. I mean, that's what you expect, and that has held up. So it was just like we expected or predicted it. Between SBRT and conventional fractionation, I'm not sure yet, but it's a little bit of a comparison of apples and oranges, just because your tumor volume is so different, right? So yes, the treatment course is shorter with SBRT, but you're also treating much smaller tumors. So I think it's fair to assume that it will clear faster because it's already harder to detect to begin with. But I'm not sure that is necessarily a good or bad sign. I think clearance in general, even with the large stage 3 tumors, as I showed you, if they clear, they do really well. So and the time points for that were 6 weeks after radiation and 3 months after radiation. So still relatively early after radiation. The ones that did well dropped pretty quickly.
Then there's a question of Panos Balampas from our own group, where we're doing some works on fragmentomics. What is your opinion on this technology?
I'm honestly not an expert on fragmentomics. I don't know.
Then next question, Maximilian Miase, thanks for joining. Congratulations for joining Anka Gross's team. I think we can repeat that. What is the dynamics and the kind of time frame and time difference between MRD positivity and the morphological changes on CT? You showed us some data already, 4 or 5 months.
Yeah, I mean, so we haven't formally compared that or analyzed that, but I think we all know what the morphological changes are just from routinely treating patients, and we all know that tumors can still shrink after a definitive course of radiation for a long time, right? I tell my patients usually somewhere between 6 and 12 months you still see further shrinkage. I would argue that in the patients that respond, that the ctDNA is actually a faster marker, and because they, as I said, they drop quickly within 6 weeks or 12 weeks. And that at that time, typically you still have radiographic tumor or residual tumor or whatever that is on scan. But I think what it also indicates is it's not just the tumor that's there. It really, what you're measuring is really circulating tumor DNA systemically. And so it really probably correlates more with also distant progression, not just with what's there radiographically at the time of treatment.
I do have 2 questions about the sensitivity again of the test. When you showed the data in your own institution, you had 100% detection rate in the stage 3, but only 60% in stage 1. Yep. So how can we be so certain that the MRD is being kind of sufficient of sensitivity? Because that would mean that you might miss in 40% of the patients if there's still volume at the same size and volume as a stage 1 disease. So what is minimal actually in this setting?
Yeah, so So we only measured longitudinally minimal residual disease in the patients where we could detect it up front. So the 40% where we didn't detect it at baseline, you just can't reliably use it. Yes, we had a few patients where then after, at a later time point, you could detect it, but it's hard to really reliably, analyze that, as you say. So for the longitudinal measurements, we made it a mandate that you had to have it at baseline in order to reliably measure minimal residual disease. You can envision that something starts out as a small stage 1 lung cancer that's caught early, and you treat it, and it's still an aggressive biology that ends up metastasizing. But I think our assays need to get even more sensitive, and there are more sensitive assays. Max Dean at Stanford has an extremely sensitive assay that is also commercialized, and there's several companies that are working on trying to further develop more sensitive assays. We were quite happy with Natera, just because at that time when we initiated the study, that was the most sensitive that we could have access to, because of that the tumor tissue informed probes that they develop. But it's really going to the next step, and we're working with them again on the next step on, can we design the probes based on FNA cytology specimens? Can we increase the sensitivity in the ground glass stage 1 opacities that are really barely visible on CT scan? So there's more work to be done in terms of the sensitivity, and especially if you want to use it as a screening test as well, the sensitivity needs to even go up further, and that's where some of the methylation-based assays come in.
What is the turnaround time to produce the tissue-informed ctDNA probes? How long does it take, actually?
Yeah, so this was done on a collaborative basis, so not in a clinical setting. It is now, since we started the project, now it's actually a clinical assay, and it's about I actually sent it for a few patients recently. It's about 2 to 4 weeks. It's not too bad. Back then for the project, it was around 4 to 6 weeks, but it was a research project.
And maybe the last question, also looking at the time, if you would be able to do one trial, would you pick early stage or locally advanced, and would you put a de-escalation or an escalation strategy?
I think that depends on which tumors you're looking at.
Lung cancer. We're in lung cancer.
In lung cancer, well, I've showed you an example. I think it's escalation of consolidation regimens, because really the main issue, despite all our advances, is still not local control but systemic progression. So tailoring immunotherapy or tailoring targeted therapies, as my colleague Dr. Shaverdian is doing with his KRAS trial, I think is the way to go. In terms of radiation, well, we would have to know even earlier, who responds to radiation, or who we could escalate radiation doses to, or de-escalate. I don't think we're quite there yet. I think more work needs to be done to really reliably use that as a marker for that. I wouldn't be comfortable doing that at this point in time.
Andreas, many thanks for this excellent presentation. Many thanks for us answering all the questions, and we wish you all the best with the move back to Europe, and warmly welcome you to the next international national meeting in Germany, Switzerland, Austria, and in the European framework. Could you stop sharing your slide for a second? Yes. Then I can switch back. Okay, I would also use the opportunity to announce the next virtual Grand Round speaker. I'm very happy to be able to present Professor Carolyn Taylor. She has been the first author of the Early Breast Cancer Collaborative Trial meta-analysis on the effect of regional lymph node radiotherapy in this huge number of patients, women, and 16 trials. It has just been published in Lancet, and he's going to present and obviously also discuss the result on the January 10th, again at 17 o'clock. I wish every one of you a very kind of a relaxing time before the Christmas, then some time with your friends and family, and warmly welcoming you back in 24 for the next iteration of our Grand Rounds. All the best, and hope to see you soon again. Bye, everyone.